Welcome, everyone. My name is Jo Buford. I'm delighted to be the moderator of this third plenary session. On behalf of the International Society for Urban Health and our co-hosts, Paho and Salarbal, I'd like to welcome you to this second day of International Conference on Urban Health, ICUH 2021, on the overall theme of transforming our urban future, learning from COVID. And I'd also like to again thank our sponsors, Fundación Botnar, Novo Nordisk, and Novartis Foundation for their support for the conference. This session will be translated, and those of you that are English speakers, Spanish speakers, you will see the interpretation globe on your screen, and you're free to join the language of greatest comfort for you. And we encourage those of you in the audience to enter your questions on the Q&A function, if you will, as you're listening to our panelists, and we'll be ready for the discussion. This plenary session will explore the specific topic of urban governance and public health systems. How do we take action to address the inequities revealed by COVID that were so well described in our first plenary session yesterday? And how do we leverage the political support to incorporate health concerns into the changes needed in the built environment, which we discussed in the second plenary? This session is in part an opportunity to explore the structures needed in cities, if you will, to connect the dots across disciplines, across sectors, across geographies, and really between levels of government and the communities they serve, in order to make and sustain the needed changes. And we are going to specifically structure on strengthening our public health infrastructure to prepare cities for future crises, which unfortunately will be inevitable, and how the public health sector can work with other sectors and with political leaders to advance health and health equity as the changes are made. We're fortunate to have an exciting panel of individuals to lead us in this discussion who bring deep knowledge and experience in making change in cities. They're going to share their experiences and lessons learned from them to create more effective governance for urban health and health equity, and to strengthen the public health infrastructure. After a brief introduction, each of our speakers has been asked to speak for about 12 to 15 minutes, and then we plan to have a very robust discussion among our speakers and with audience members as you enter your questions in the Q&A function. So let's begin. Governments really hold the ultimate responsibility for creating the conditions that allow people to be as healthy as they can be. And governance for urban health requires political leadership that recognizes the relevance of decisions made in sectors beyond healthcare and beyond health, really, in determining health. Governments also have responsibility for creating and sustaining effective public health systems and infrastructure. And at the same time that the authority assigned to regional and local governments varies by country, it is increasingly apparent that governments must interact effectively with a growing number of governmental and non-governmental actors to fulfill their responsibilities. In a discussion before our session, among our panelists, we decided that we must really, let's see. I'm being told I can't screen share when someone else is sharing there. Let me try again. Sorry for the interruption. There we go. In the discussion that our panelists had before the session, we all agreed that governance is an area that is much discussed, and governance for health is a major goal, but it's really critical that we define what we're talking about as we begin the discussion. So I have three quick images here just to lay the groundwork for our discussion. Oh, I think I have three quick images here. Hold on a minute. I try to change again. for some reason I'm not.
We
Can I
can
move
see
it?
it. You just need to put it in screen, full screen.
Oh, all right. My apologies. All right, let's try this again. First of all, in our discussion, we agreed on a very simple definition of governance, which is the alignment of multiple actors and interests to promote collective action towards an agreed upon goal. So while historically governments have often had this responsibility without involving other players, that world has changed dramatically. So we share this notion of what we're talking about when we're discussing the issue of governance. The second area that we wanted to clarify is what we are talking about when we say broad determinants of health. In order to really achieve healthy cities, we know that we have to work beyond the formal health sector, both either public health or healthcare delivery, and develop models for government and governance and political leadership that can bring together multiple sectors who very often are, in fact, the much more of an influence on the situations in communities that create the opportunities for health than access to healthcare or than the health sector, which are important, but must really not dominate the conversation. And finally, another term that's applied often to governance for health is the context of health in all policies. It's been around for a long time, and we wanted to share just some key elements of what we again will be talking about when you hear the word health in all policies. Obviously, it's about decisions for or against health in other sectors, hopefully increasingly with evidence based on making healthy decisions, but also highlighting the importance of governments working across sectors and the importance of community engagement and equity and social justice in achieving effective health in cities. So with that, I will stop sharing and move on to our panel. And our first speaker is Remy Sichaping, who is the Chief of Policy, Legislation and Governance within the Urban Practices Branch of UN Habitat. And he's currently overseeing a new and I think very exciting segment of Habitat, really looking at really the core issues of the elements that allow for effective governance. He has coordinated global, regional, and country projects and programs for UN Habitat in Africa, Asia, and Latin America, and has worked on land management, climate change, and with state governments in other countries. So he's very well experienced and positioned to really talk about the challenges of governance. And he's also a geographer. I always like to mention the multidisciplinary nature of our participants in ISUH and ICUH. So Remy, over to you, please.
Thanks, Joe. As I predicted, confirm my slide and to share, which I did before. But Gemma, do you have it? I think I can't find it. Anyway, a pleasure to be here to share some thoughts from UN Habitat on what we are doing on the urban governance in general and the nexus with health. From UN Habitat perspective, this is a long-standing topic that we have been working on, but we slowed down some time ago, and we have revived that in lately. So I would try to share with you what we have been working on and some of the ingredients that we see from our perspective that seem to be which can work, which are working or can work to make governance more effective, to share what Joe called about the collective actions and interests. And this is my thought would be very much emulated by the current pandemic. So I will be referring very much to the current situation so that we can see the relevance of governance, urban governance for that matter, in this context. So as some of you might not know, UN Habitat is a human settlement program that looked at how space and people interconnect, and that requires design solutions that make place, people, and policy work for all. And that means that we can't work without engaging with all tiers of governments, with civil society, all actors. So it's really about that governance. How do we manage our shared interests, our common interests? At UN Habitat, we feel that in this context of COVID, as I mentioned, this will be one of the key threats in my conversation with you guys, is that many of you are aware that the COVID cases are in what we may call urban settlements, estimated to be 90% of COVID-19 cases were in urban areas, meaning that when you take the context of COVID-19 as a health issue and how you manage in such settings, it calls upon the issue of how do you manage access, how do you manage prevention measures, how do you design urban solutions in terms of mobility, food, and well-being, livelihoods to ensure that that element of equity that Joe mentioned earlier is sustained. And to do so, you have to check that it's effective, meaning that it's not negatively impacting some groups, that it's possible to share responsibility and roles, meaning accountability, that you include anyone that might be interested, any actor, any sector. So that elements of intersectionality and inclusiveness is very much at the heart of our thinking and engagement on the issue of urban governance. In the context of COVID-19, it's clear that what we were looking for, testing the notion of governance as being perceived somewhere else, is that what type of arrangement, other institutional actors and interest arrangement are effective to respond to COVID-19? What type of health impacts, are more can be more, supported or can be assigned to a poor or, effective governance. We also looked at some of the measures in terms of timeline, immediate, long-term measures, and see what type of governance, how agile different governance arrangement could be set to engage with over time with the importance of taking into account space and time, what works where, when, and how. We also looked at really some of the fundamental principles that globally are seen as
Remy, I think you're frozen. Can we get some assistance?
When they are frozen like that, it typically means they've lost their network connection and will probably drop and then rejoin.
He's back.
Okay, sorry. I don't know at what point you lost me. You lost my.
I think you were beginning to you were reflecting on what had been learned in COVID so far, but only the first couple of points. You were looking for flexibility and governance structures that were responding well, and I think that's where we lost you.
Oh, sorry. Okay. So yes, we are looking at asking those questions, and as we are looking at different policies, different interventions that are out there to see which one had worked, which one had not worked, and why. And in the end, I will show you what we have found that came out very clearly in our intervention. So then I was talking about the notion that came very much at the forefront of urban governance in the context of health, and health is really that equity. So when you are now talking about health equity as the society does, urban governance is, when it comes to health, is all about equity as a principle. So that's one of the key findings that we had noticed. And by equity, we mean, is it equitable in terms of availability of services, infrastructure, accessibility, is it acceptable, legitimacy, quality, all these things in the notion of equity. So for us, as one of the key findings in terms of principle that had to be promoted and acknowledged in the context of urban governance for health, is that reinforcing that notion of equity that the RCUH had been promoting for long. So that's a good validation in that context. The other notion that came very clearly to us was this issue of inclusiveness. Inclusiveness revisited, I would say, because it's not longer about the rich and the poor. It's not about only stakeholders, but we start looking at some underlying conditions that were not spatially disaggregated when it comes to people living with some health conditions, or people living in some type of housing. It could be high-end housing, but not conducive. It could be in terms of location of services. So the inclusiveness had come very clearly as one of the key principles or key values we have to keep on when we are talking about urban governance in the context of COVID and any pandemic perhaps in the future. The other is, I just came from another discussion where it became very clear that the governance is no longer public governance. Urban governance is really about the negotiation, the interests, mainly about the public and the community, the civil society, let alone the private sector, as some would say. So it became very clear to us that the community, in terms of governance, is very much essential. So that is calling upon us to look at revisit what we may define as urban governance, where we usually say it's about engagement with the national and subnational authorities and other stakeholders. But in this time, we think that in the context of COVID, community really had been at the forefront and should not be ignored in the context of COVID and pandemic. The other part is the capacity. It has been squeezed during this COVID-19. So we felt that one of the key lessons is that when we are dealing with urban governance, not everyone is at the same level of information, data, understanding. That's why you have the fake news for now. So it's a matter of governance as well. And I mean, that's an expression of governance which had not worked when you have misinformation, where people believe in other systems than a collective decision understanding. So that ability to build the capacity to understand, have the shared vision, share ways of managing the pandemic in a city or any settlement is a sign that we have to reckon with moving forward. The other point that we just to finalize in terms of key lessons is really about authorities more recognize that there is a need to integrate corporate work at multi-level, multi-tiered governance, and put community at the center. They should not come as add-on, put them at the center of the governance. That's what one of the first lessons we have identified in the 2021 Cities and Pandemics report that we released in April. The second lesson when it comes to governance is that multi-governance is necessary for any mitigation measure. If you don't work collectively with all these actors, it's not going to make really sustainable change. The other part is really linking governance. Even urban governance should not ignore the rural and peri-urban areas. Otherwise, it creates more spatial inequity. So we felt that through our research and review of policies, that policies that were too much place focused because the pandemic didn't know boundaries. Even when we put lockdowns, they still spread. So this issue of connection was there was a third lesson we drew from the governance. The other one is the social needs. We didn't look very much at the social needs. That's why in some parts, even in Latin America, there was a social movement to rebuke, even now with the vaccine hesitation. This is part of the governance as well. The other one was really about bringing back the issue of transparency and community engagement, as I said, and trust in our governance system and our rapport and our network and connection with other people. And then the last one is that is the digital. We can't today discuss urban governance without taking into account the power of innovation, of digital, of technology. And we have seen that urban governance is not the same as before. The way people engage with discussing, debate, ideas, community thoughts had evolved. So this is what I had to share. This is what we have found out. And this had really put us, make us rethink what we mean by urban governance, and urban health have been a great help for us to rethink urban governance as UN Habitat. So thanks a lot, Joe, and I look forward to further discussion.
Thank you very much. You really set the stage, and I think importantly, focusing on governance and the expertise needed within a group to tackle that at UN Habitat is going to be very, very helpful, very productive going forward. So thanks for your comments. Our next speaker is Dr. Srinath Reddy. I may invite him. There he is. And he is president of the Public Health Foundation of India, and has formerly headed the Department of Cardiology at the All India Institute of Medical Sciences in New Delhi. As under his leadership, really, the Public Health Foundation supported the creation of 5 Indian Institutes of Public Health to advance multidisciplinary public health education research and engaging health technologies and implementation support for strengthening health systems. So here's someone who's really seen what's involved in implementing public health infrastructure in a country as complex as India. So he also has been a visiting professor of cardiovascular health at the Harvard School of Public Health, and is, I think, known nationally, especially internationally, actually, for his engagement in NCD prevention, especially cardiovascular disease. And he has been president of the World Heart Federation, and was the first Indian colleague to be elected to membership in the US National Academy of Medicine. So we're proud of that. Today, although he's going to shift a little bit in what you might normally expect him to talk about, to really talk about the role of urban public health systems in preventing and managing communicable diseases. And he's going to share with us his experiences working with multiple cities during the COVID epidemic, and really talking about how cities respond and what he sees as the key elements of a public health infrastructure that really need to be mobilized and supported. So Srinath, over to you.
Thank you very much, Joe. As you said, it's been a shift from NCDs to communicable diseases, but really there is so much of crossover now and interconnectivity that really they do not exist in silos. We have seen how cities of the 19th century were filth-ridden and had a severe spate of communicable diseases. But then, with the sanitarian movement and the germ theory coming in, and over a century of high-speed economic and social development and amazing scientific advances, the spectrum and risk profile of communicable diseases has changed in the urban environment. Water and foodborne communicable diseases have largely receded due to clean water and improved sanitation in many parts of the world, but not uniformly distributed in terms of benefits, even in the large cities, particularly in some of the slums, which are continuing to be disadvantaged. But we do know that these diseases, that the water and foodborne diseases, can still occur during extreme weather events, which still pose a threat of water contamination and disruption of the food supplies. But we also recognize that over a period of time, communicable diseases associated with high-risk behavior emerged, like HIV/AIDS, and especially in urban environments. But it is not that infectious diseases of other etiology have totally disappeared, because now we are seeing a spate of vector-borne diseases rising, like dengue, chikungunya, urban malaria, spurred by global warming, a part of the climate change crisis. We have also recognized that while clean air was assured after the miasma of the 19th century was partly cleared, but still now we have a return of air pollution in the urban areas because of an expanding industrial production, vehicular emissions, and expansive urban construction, which have all added new sources of air pollution, which reduces immunity and increases the risk of respiratory infections, especially because of a variety of viruses and bacteria attacking the compromised lungs. And the respiratory viruses indeed love the urban environment, as we have seen in the influenza pandemic of the 20th century and the current COVID-19 pandemic, but also we have seen several other outbreaks of respiratory virus infections, basically affecting many of the cities in the last century and early this century. And the reasons are very clear. First is population density, especially in the slums, where you have great difficulty in terms of providing adequate housing, water, and electricity, ventilation, and assured sanitation. And when these are all compromised, we recognize that there is a great opportunity for infectious diseases to spread, and particularly in a very inequitable manner, affecting the poor who are crowded into slums. And there the local administration certainly has a tremendous role to play in ensuring that each one of these, that is housing, water, electricity, ventilation, and sanitation, and clean and green spaces are provided to the extent possible. But we also recognize that the other element that actually pleases the respiratory viruses, such as COVID-19 virus, to spread rapidly is travel intensity into and within cities. And there, urban design and transport plays a great role, because the virus travels with people and celebrates with the crowds. And how we actually design our cities, both in terms of the housing as well as in terms of the transport, is going to be a very important element of urban governance that we must really look at if we are wanting to prevent communicable diseases spreading rapidly. We do need to strengthen our public health systems in urban areas. Urban health has not always received as much attention as it should have, and particularly urban primary care has been greatly neglected. If you really look at what the need is, we do require strong surveillance systems at the entry points into any city. That is partly a federal responsibility, but also partly the responsibility of the local administration. We require timely and intensified testing as needed by the state of the pandemic, and that again is a responsibility of the local administration. But we recognize that tests can be false positives and false negatives, miss a large number of cases. So symptom-based syndromic surveillance of people who are visited at home by primary health care teams is absolutely critical, who can then have early case detection, prompt testing, contact tracing, and all of these are going to be very important, even if we want to detect the variants which are likely to be springing up and causing more damage. Therefore, urban primary healthcare is absolutely pivotal, even for detection of comorbidities like hypertension, diabetes, coronary heart disease, chronic respiratory illness, all of which fall into my area of non-communicable diseases, which actually increase the risk of severe disease and death from any respiratory virus. Those also need to be detected early and treated early, or even prevented by competent urban primary healthcare systems. Therefore, building public health capacity and competencies in the municipal system is an important objective that urban governance must address. And this is going to be absolutely important if we want competent governance. But we also recognize that primary healthcare also is another element which is very critical for reducing fear, stigma, which usually come out when there is a pandemic outbreak. And that is something that we must really look at. And we have seen both fear and stigma stalking people in the initial stages of the pandemic. We also must recognize that vaccine confidence is again built by competent primary healthcare teams. Therefore, the primary healthcare system, which has been long neglected in urban areas in many countries, must now receive much greater attention and resources. But this also requires community engagement and community networks. They're absolutely critical. And we recognize that even for a competent pandemic response, like we have seen in India, in the city of Mumbai, where there were many slums, very large slums, some of Asia's largest slums were in Mumbai, and it was feared that the pandemic would be a disaster, a catastrophe, with several thousands of deaths happening. It didn't happen because the municipal administration decided very wisely that they would engage the slum community, the leadership of the residents there, and arrange for prompt testing, arrange for treatment, if not within the slum, on the periphery of the slum. They ensured that the elderly people who were at greater risk were shifted out of the slum for isolation till they could be protected. So there were multiple areas of engagement that happened with citizen participation. Also, ward by ward, community teams, as well as primary healthcare teams, built up partnerships for tackling the pandemic, and the expected catastrophe didn't happen in the Mumbai slum. So that is where competent urban governance becomes a very important element. And for this, we require both data as well as decentralized governance. For example, even if cities are going into lockdown, which has become now some of the regular feature of some of these pandemics, how do you decide when a city should go into lockdown, when it can release itself in stages from lockdown, when it can be fully freed, for which we require data which are decentralized. And therefore, you may have to take local decision-making in terms of what stage of the pandemic is there and how do you release different parts of the city in terms of, or even different cities from the lockdown. And therefore, empowering mayors and municipal authorities is absolutely critical. It can't be all top-driven from the federal government or even the provincial government. And that is something that we must recognize, that absolutely empowering local governance is going to be very critical, because you require micro-planning and contextually adaptive implementation. So you require regular monitoring of data and looking at the threats and opportunities for action. And therefore, you require participatory governance and participatory leadership, including of the community leadership, with multiple agencies joining hands together. And that is where you really democratize the health system at the local level. And therefore, you must have people-partnered public health and data-driven, decentralized decision-making. We have spoken of partnerships. Yes, we do require partnerships. The frequent term used is public-private partnerships. I would say the term should be partnerships for a public purpose, for which you can have the public sector and the private sector join hands, different private sector entities can join hands, the civil society can join hands within itself and with the private sector or the government. You require an array of partnerships for public purpose with clearly defined deliverables and accountability mechanisms. So we do require multi-sectoral coordination and convergence of services closer to the ground level, and larger the number of partnerships that we can assemble, the better it is. And this, of course, requires shared vision and shared values. But there are political barriers. The political barriers are concentration of power and autocratic governance, where a national government or a provincial government is very reluctant to cede power to mayors, to municipalities, and to local governance, where they do not welcome citizen participation. We know that citizen participation has been very effective in the municipal health governance of Brazil, for example, or in Thailand, for example. But not all governments have been welcoming at all stages of having that level of local autonomy and in terms of citizen participation. Therefore, we need democratic decentralization, and we need to use the learnings of this particular pandemic, where we know that we cannot achieve our goals unless we actually empower the local governance along with adequate coordination with other elements as well. To conclude, I would say that what we really require is also to use information technology for citizen participation, for example, crowdsourcing of data for early alerts of infections happening so that you can actually detect clusters very early. But we must also ensure that we detect and ameliorate inequalities which exist. And addressing inequalities has to be a priority of good governance and a measure of accountability. The slogan has gone forth from the United Nations and WHO that we must build back better. I do not think it is build back better. It is build forward better, broader, and fairer. And that is where urban governance now must head, whether it's control of communicable diseases or of non-communicable diseases. Thank you very much.
Thank you very much, Dr. Reddy. Really important points. And you've given us a terrific segue to our next speaker by ending on the point of equity and fairness. Dr. Mary Bassett, who will address us next, is director of the FXB Center for Health and Human Rights at Harvard University and professor of practice of Health and Human Rights at the Harvard School of Public Health. She has more than 30 years experience in public health, and I think a signature, I've had the privilege of working with Mary for a long time, especially as Commissioner of Health in the city of New York. And she really has, I think, uniquely taken a sort of conceptual framework and lifelong commitment to equity and social justice and implemented it in terms of public health programs, both in her work in New York City on looking at structural racism and its effect on her own department and publishing a good bit about that and cautioning public health professionals to think about those issues importantly. And then also really looking at what were actually quite dramatic reforms under Mayor Bloomberg, but had not really spread beyond Manhattan in many instances. So really looking at the equity question in terms of other boroughs of the city. Mary also, which many may not know, lived in Zimbabwe for 20 years and was a faculty member at the university medical school there. And I think has always certainly had a special point in her heart for Africa, the continent of Africa, and for the country of Zimbabwe, and has also led the African Health Initiative and Child Wellbeing Program at the Doris Duke Charitable Foundation. So she is also a member of the U.S. National Academy of Medicine. I brag a little bit, and won a very esteemed prize from the School of Public Health at Columbia, the Frank Calderon Prize, which is not given to many people. So I wanted to mention that as part of Mary's background. But Mary's going to talk to us really about a social and racial justice approach to urban governance for health and looking at cities as sort of gateways. And what did we learn from COVID that helps us address this equity issue more effectively in urban governance? So Mary, over to you.
Thanks very much, Joe, for a really kind introduction, and to my fellow panelists for their contributions so far. And Dr. Reddy, I want to thank you for such a rousing conclusion. I have slides, which I hope I'll be able to share. If somebody can tell me whether I'm yet in presentation mode.
Not yet.
Not yet. Okay.
I know from lessons when I wasn't and slowing things down. So
yeah, I apologize. We practiced this, but it doesn't seem to be working. I don't know what to do.
Go to slideshow at the top, perhaps.
Yeah. Okay. I can. It's not allowing me to do that. All right. I'm going to have to. I apologize, but I'm going to have to close this down and share again. And I apologize for that.
Okay. We're all feeling our way.
This is the thing with Zoom. For all of us, it's just been a real, oh gosh, a
Challenge
real
and
hassle.
opportunity at the same time. One of
Yeah.
the things that we were talking about earlier, in sort of debriefing some of the technical glitches and advantages we've been having, is that in normal times we'd all be running around to a room and getting a tech to come in if something didn't work, and everybody would sit there quietly. But it's the gaps are so much more apparent here in the tech world than they
Now,
are.
I haven't shared yet. Is that correct?
Not yet.
Okay. Am I getting there?
You're getting there. So if you go to slideshow, I think,
I don't know.
and then from the beginning, you should be in business.
I've tried that and it's just not working.
Double
It's
clicking,
so
maybe?
strange. Can you see anything? Not
You see,
yet.
yeah, we can see your opening slide and we can see the slides going down.
I see. So it's not in slide mode yet. Maybe I need to.
Mary, it's Nicola here from Elsevier. Do you want to just click? Yeah, that bit's just gone. Just try clicking on from the beginning now.
I have. Does anybody have my slides?
Okay, bear with me one moment and we're just going to get you some assistance here. Thank you, Mary.
I'm going to try again one more time.
These are the things that work in rehearsal and don't work.
I really
stage.
apologize. I told them that this is what drives me crazy. How's that?
There you go.
Do I need to swap my slides to display to
Yes,
get the right
that
display?
would be great, Mary. Thank you.
All right. Apologies to the
Perfect.
audience.
Thank you.
And
You got it.
fortunately for me, the previous speakers have said many of the things that I was going to begin with. So I'll just sort of zip through my initial slides and then spend more time on talking about governance. But one of the things that I want to point out is that in terms of COVID and cities, a lot of focus was on cities as just places where there were too many people to be safe. And that was not, in fact, what the problem of cities has been. The problem of cities is how they're structured and the fact that many people who live in cities are extremely poor, not only in the developing world, but also in wealthy countries, including New York City, one of the wealthiest cities in the world. And we saw this, I would say to you, during Ebola, which exposed what urban growth had meant in Africa. And Dr. Reddy spoke about this. The urban slums of Africa don't have the standards even of 19th century public health, meaning no water, no sewage, and completely informal building developments. So I'm going to turn now to New York City, which is Dr. Buford has mentioned had been my home for a long time. It's the largest city in the United States. It's the only mega city in the United States. And it's a city where there is no majority racial ethnic group. The largest single group are people who are classified as white, and they comprise just about a third of the population. It's also, despite the images of the city and its iconic skyline, a city where where half of the population lives at or near poverty, and it's an immigrant city with their children. Half of people who live in New York, more than half of people who live in New York of immigrant origins. And so for much of the population, New York City looks like this: dilapidated housing, overcrowded. And when COVID hit, people talked about we need to get out of cities, and the wealthy did do that in some numbers, mostly from, I hope you can see my arrow here, from the wealthiest section of Manhattan. But in fact, out of a city of some over 8 million, the number of people who left were not that large. And we also saw, in line with what has been seen everywhere, is a real geographic variation in who got infected with COVID, who got hospitalized, and who died of it. Those of you who know New York, this is cases, may notice that this is Staten Island, not a Black and Latinx part of the city. The darker the color, the higher rate of cases. And these are mostly public servants, actually, police officers, firefighters, and the like. But by and large, as elsewhere, the initial burden of COVID was and continues to be felt by people of color in the United States, Black, Latinx, Indigenous. People attributed this to crowding, and they got crowding mixed up with density. The densest part of New York City is Manhattan. It's more than twice as dense as the Bronx, which is the poorest county in New York State, and one of the poorest counties in the United States generally. And there you can see that the density is less than Manhattan, but the crowding is twice as high in the Bronx. So density is not the same as crowding. And the poorer, less dense parts of New York City are in fact the most crowded ones. And that contributed to the still shocking toll of mortality with over 33,000 deaths now recorded in New York City as a whole. The United States had up to 20% of the global mortality burden of COVID. It's lower now, but still hugely disproportionate, and that's not just a reporting artifact. And of course, as I've said, it was very different by race, ethnicity, taking age into account. Black Americans had between 3- and 4-fold higher risk of dying early in the pandemic. And this was really extreme for people in midlife. For Black Americans between 35 and 44, that the difference as compared to whites was 9-fold. So I want to say, because this is an international audience, I want to just be sure to make the distinction between race and racism, that these differences that we see are related to what it means to be a person of color in a society which has embraced a racial hierarchy that places whites at the top. And the consequences of this are felt in many spheres. And Professor Reddy talked about that as well, in the ability to get safe jobs and the ability to live in decent housing or in neighborhoods which have decent air, the impact of residential segregation, the impact on politics, and the impact on the ability to access healthcare, all of which have to do with the state of governance. So these are all the effects of racism. They're not some intrinsic feature of being classified as white. So what made New York City vulnerable was poverty and racism, and not density. And it breaks down into the things that I've already mentioned. Too many people in overcrowded housing, too many people who had to go to work because they needed that paycheck to live, and too many people who lacked health care. And I'm going to try and slow down a little bit here, because this is some of the things that happened, and I think are ways in which we've learned. Some of the things that were innovations that New York City and many other cities around the world adopted that I hope can be retained. One was the idea of closing streets so that people could walk down streets without being shoulder to shoulder, and increasing the number of pedestrian walkways, encouraging cycling. And in New York City, this included the advent of electric scooters, and new companies emerged that have placed these scooters all over the streets, running the public transit more often, moving dining into outdoor spaces, and then taking policy decisions like ending evictions, so that people who lived in housing and couldn't pay their rent wouldn't become homeless. Other innovations are kind of nerdier, but I want to highlight them because we can't look at inequities unless we have the data to document them. And there were real innovations in this. For example, we could use cell phone data that could track, in a way that is a bit eerie, but see what communities still had patterns of commuting, meaning that they were likely still going to work. How many people were in fact staying at home during the city's period of lockdown, improving the capture of racial ethnic data, which is woefully inadequate in the United States, not so bad in New York City, but still is not good enough. And making these data publicly available so that people outside of government could look at the data and analyze it. And then there were other interesting things like the use of wastewater to check for the virus, this novel virus, and see where it was, even as a mechanism of surveillance. Clearly, one of the key things that came out of COVID was the fact that the U.S. public health infrastructure is terribly fragmented, that its IT capacity was inadequate, and the U.S. spends less than many wealthy countries on public health. It has a very decentralized system, which is okay in many ways, as Professor Reddy has mentioned, but doesn't work so well when you need to have a national response. And we had real fragmentation by jurisdiction, which continues to this day. And of course, as the pandemic began, the United States central leadership, its federal presidential leadership, it's really stoked a distrust in expertise in general and in science in particular. I found the really good, from a year ago now, policy brief issued by the UN that talked about how the sort of buckets that we need to really tackle these inequities from a governance perspective. And I'll take my last few minutes to talk about some of the things that they highlighted. And I have taken the initiative to highlight some things that I thought were particularly important. The importance of disaggregated data gathering and utilization. Sorry, I've moved my picture of myself. Having a moratorium on all evictions was recommended by them. Ensuring the continuity of services, the investment in affordable housing, and of course, increasingly, we're all thinking about the importance of guaranteeing the equitable distribution of a vaccine, which many people now see as the way out of the adverse impact of COVID-19. But I hope that this group, all of you, will be aware that how our cities were structured drove exposure, not only the absence of a vaccine. So with that, I think that's the end of my slides, and I'll stop sharing. Thank you all for your attention.
Thanks, Mary. Terrific. Really getting into the areas in which the equity question comes up very dramatically in urban governance. So our last speaker is an elected official, former elected official, Charlotte Marchandez, is head of partnerships and engagement for the WHO Academy and former deputy mayor for health and environment of the city of Rennes in France. She is certainly an international expert on governance and empowerment, and has focused a lot on global health and resilience and the environment. She's, I think, wouldn't have been an elected official had she not been active in civil society in her city of origin, and was president of the WHO Healthy Cities French Network, and is now co-chair or has been co-chair of the Global Urban Air Pollution Observatory called GUAPO, which is a European network, especially in Francophone Europe and Francophone US, internationally, and spreading beyond that, and has really been an important advocate, I think, and spokesperson as a elected official on whole of government and whole of society approaches. So, and to getting to health at all as a governance approach. So Charlotte, over to you.
Thank you very much, and thank you for the invitation. Yes, indeed, I'm not elected anymore, so I I don't have this kind of responsibility. Well, not, yeah, I wanted a post, but indeed I was elected because I needed people from civil society to come in, which is a good news for all of the people listening. If you want to go into politics, please go. We can do something. So anyway, I'd like to talk about health and politics and how can we empower decision makers. And I do believe this is our role as civil society, as researchers, as public health people to get into that. And the former crisis has shown that. We all say, and we have this publication saying health is a political choice, but what is a political choice? How do they make decision making? And again, this was a question I had 2 years ago, but what now? What the crisis has told us about how politicians make decisions. Do they even read UN briefing papers? Well, from what I know from them, no, they don't. So please meet Mayor July. She was just elected in a small middle town and she campaigned for better school, more green space and a safer city. Her background is human resources and she managed a team in a tech company. It's her first mandate. She does not speak English, as you see from the bench, she's French. She never read a research paper. She doesn't know about academic. She did an MBA and she's not very much into research. She does not know Sustainable Development Goal, as many local politicians don't know about it. And she is really onto ecology and sustainable development. But what about health? Yes, she has a great hospital and she commits to have more doctors. That's about what mayors comes with. And that's okay because mayors, elected politicians, are not health professionals. And the aim is, how do we train Mayor July into health? Well, we don't want to share to her all our public health, determinants of health. The diagram of this grazing is the obesity system influence diagram, which shows all the factors that influence obesity from all the things we've been talking before in very eloquent from the previous speaker. We can tell her also about, Alma-Ata, that. She doesn't know about Alma-Ata. She knows about air pollution, but she doesn't know how many particulate, how many elements you have. So you want to tell her about public health in a way that's clear and in her frame. She's a mayor, she doesn't have lots of time. So we use this kind of tools to show her that it's win-win, that if you try to influence on the people, on the health hazard, she will need lots of energy. And when she act, and the previous presentation was really clear on that, when you act on the housing, on the poverty, well, you can really improve the health of the people. I will not get into the equity because we want to have time for questions, but I think the picture speaks for itself, which is a good thing about pictures. How do you advocate for Mayor Julie to put health at the top of her agenda? Mayor July has lots of things to think of: housing, urban planning, security, innovation, international relationships with twinning cities, procurement. Where health does belong there? And how do we make it not silos? How do we make not that it's a fight for resources, like urban planning has a lot of money and health have much less money? Well, we know that political process is complex. Decisions are taken by public opinion. We often forget that, but you're elected. You want to make the public opinion happy with you. You have local competition. If the other city is doing something with lots of bikes, well, maybe you want to do more bikes than the other cities. Of course, it's economical interest. The medias, you cannot imagine. Well, I could not imagine before being elected how powerful is the media in the decision making, even in medium cities. Of course, you have the values, where she was elected with, social movement, her personal experience. She's healthy. She's a kind of high income person. She doesn't know that you don't eat well when you're poorer because you don't want to, because you can't. She doesn't know about that. She thinks when you want, you can. Just cross the road and you'll find a job. And there's evidence-based research. How does she access that? When does she meet researcher? So we want to empower Mayor July, telling her health is a positive concept, showing her how health in all policy is about making public health great again, how we can influence with health all the policies we've seen before for greater good, because it's good for housing to integrate health, because it's good for green spaces to integrate health. And because we're from public health and Alma-Ata and so on, we want to tell her that we need democracy, that when you listen to the user experience, you have a better design than when you don't. Once again, sometimes a picture is worth 1,000 words. So what we want is to tell her that we can do win-win strategies, culture and health, finance and health, transportation and health. That's the aim of our advocacy for health in all policies. What we know is that we can do it and we have experiences. So when I was in Rennes, it's a WHO healthy city since 30 years. We have lots of partnerships in the neighborhoods. We have been doing data, and our previous speaker said it's so important to have data within the city. These are the neighborhoods of my city. And you see that people are dying more in the poorer city, as we've seen in New York too. Before I came, we didn't have this kind of data. How do you decide? How do you make decision making when you don't know where people are and what is their state? And in France, for instance, it's forbidden to make racial data. So we cannot know, we know, but we cannot really know, strongly know who is actually affected. We have the luck to have strong link with researchers and with the National Public Health School. So we have been into very big interventional research project that gave us other data and led us and told me what to do when I was a mayor. They were telling me how complex is sustainability and health, and they helped me on that. And we have also lots of things in the neighborhoods with the communities, because we cannot do anything for them without them. Health in all policies was also a strategy. This is the health, this is the organogram of the city. And we linked with sports, we linked with urban planning, we linked with culture, with habitat. Some of the connections worked, and we had great opportunities to develop health in all policy. And some other did not work. We have to be very humble when we develop that. A colleague from mine, he was on the sport, he wanted sport to be competitions, sport to be something to shine and to send people to the Olympics. Health and sport, not interesting for him. Well, the next one will do it. It's okay. We have so many opportunities. This is a great thing about health. We can do so many things. So we went for culture and we went for urban planning. And urban planning is, I think, the best way of really integrating health into all policy, health into the governance, because it's where we have money. It's where we can target so many social determinants. And it's where the eyes are showing. It's where we change the daily life of people. I will not go into the details, but we have so many things, amazing material now written, and that helps the decision maker on healthy urban planning. And now COVID-19. Well, you can guess how my July could deal with all the different informations we had. I was still mayor for 6 months when COVID-19 arrived. It was so hard to know what to say to the people, how to decide, how can we do, with whom can we speak, what the national government is saying and what we can do. What I can tell you is that because we had health in our policy, because the health sector was seen as a resource for other sectors, we could do many things. We could do bicycle lanes, as you say in New York. We could go to the poor people. We could call the hospital because we knew each other and say, oh, let's make an hotline for psychological help. We could have economic actors making masks locally and not importing from China. So we could do many things because we had these healthy cities. And what we've seen, and the lesson learned at the WHO Healthy City Network was networks were robust. And we had weekly meetings with healthy cities at national and European level. We shared resources. We know that local partnerships, that changed the way. And in cities where we had this kind of partnerships, everything went much better. When we had champions in communities, and the example before was really clear, it worked better. We had less people dying when we had a good community. when we had people telling us, hey, please, can you come? And I've been working also in Mayotte, which is an island in the Indian Ocean with very much poverty. It's French, but it's really, really poor. I mean, when they had a poor health ambassador in the slums, they could call the doctors and they would come for COVID-19 patients, where in other places they could not. So we really, really, really want to empower more health ambassadors in communities. And what we know is that political leadership was key. And on the bad side and the good side, when you see in other places. But what I didn't see, maybe you can tell me wrong, that we didn't have so many research on what makes the people take the decision. How can we influence the decision making? How can we make the mayors or champions in the next step in the future? How can we really develop all this framework for the future? How can we make health girls and champions to break down the silo and prepare for the next pandemic that will come? So thank you.
Thank you, Charlotte. That's terrific. Let me invite all of our panelists to open their screens, and I think we'll stop screen sharing, Charlotte, and then we'll get into the Q&A segment. I hope we haven't lost Remy. Oh, there he is. Good. Excellent. Okay. I want to start. Charlotte gave me a great opening. I'm going to invite again, remind everyone who's watching, please enter questions into the Q&A function and we'll get them and make sure they're asked during the session. But let me start. Charlotte ended with this: how can we question? How can we get basically strengthen urban governance for health? How can we create sort of informed political leadership to engage communities, to do other things, to do some of the things that she really outlined. So I wanted to start the discussion. Really, you know, my impression is that governance is talked about a lot in the global literature, but I have yet to see systematic investment in the kind of capacity building necessary to strengthen government, or in the kind of, as Charlotte's, you know, sort of research attention to the issue of governance and how partnerships can work better. I mean, Remy's unit may start generating that out of UN Habitat, but I wanted to ask, what have you all done, you know, to bring evidence into government and to strengthen the capacity of government to function for health? Mary, you're looking very expectant. I'm going to ask you first. Why don't you get started?
Sure. Thanks. I really want to, you know, commend Charlotte for really a fabulous presentation, and also describing such great work. My experience in New York, which was that it was better for me to lead with equity in all policies, because when people heard me say I wanted health in all policies, it felt, you know, government tends to be very siloed, and they felt like, okay, all of us are going to do your work, which is true. It is health work to have better housing, better parks, more access to healthy food, all of it. But the point is that we have that in many cities, but it's not equitably available. So that was the language that I used. And I think that Dr. Reddy pointed out that often there's an ability of smaller jurisdictions to act more independently than central government, and that's why I think it's really a good focus to look at local jurisdictions as a source of innovation and democracy, frankly.
Remy, maybe you could jump in here, because I know the work your group is doing is really trying to, I mean, obviously the reality of national governments is local government is given or not given pretty variable responsibilities, but how are you tackling this issue? I know you're looking at cities and regions and territories in your work.
Well, I agree with what was said earlier. Just to say, perhaps what many are interested in is the how, you know, how to do it and where this had been done. So Charlotte's question is well founded. From what I mean, just to give you an idea of some of the projects we have or engagement on the capacity development front, with the Hague Institute of Governance, we have this program that we are running on urban governance. And this year was very much on health. How do you manage that? on the evidence, as I mentioned earlier. We review 250 policies related, urban policy related to health in the context of COVID, in the finding that I share with you. So data evidence is key, because many politicians learn through, some are through guts, but some actually learn from others. They learn from others more than from their community. They copy, not copy, but they draw lessons from that. That's why that networking is very important. So we have also noted that data and information, you can play with that. You have the same data, but the politician can sell it as a good thing, you know, depending on how you manipulate that. So data can be a very dangerous thing as well. So if you don't, depending on who use it, on what purpose, and you know, it could use that for the campaign, something to be done, and not to blame and shift the games. So the third thing that is very clear when it comes to urban governance is clear roles and responsibilities. Because when you know who is doing what, and then you have the issue of accountability, who can call, you can call, and so forth. If you are a mayor, you know your responsibility, you know what you are supposed to be doing. That would help. So this issue of capacity development, the issue of capacity building in many ways, the issue of learning from others, you know, open up, and it's important. And finally, yes, you have to be able to connect with be able to listen to the communities, as many have said here. Communities, they know more sometimes than you as a mayor who's supposed to lead them. But if you lead from behind, they should be the one guiding you to what their needs and what their demands are. So be very much on the demand, the needs side of your community. The last point I want to highlight, you touched on the territorial. Many, even if you are in a city, you are not an island. The neighboring communities, your neighboring cities and territories are very much important. Don't step aside and forget about other communities, other networks, and because even people in your communities connect with others. So these are four elements I would say in terms of the how to make the governance work. Over to you.
Thanks very much. Srinath, let me ask you to jump in here. You raised the question of more centralized decision-making not being as functional. You also raised the issue of informal settlements, which is a huge issue for local governments and having jurisdiction and authority. Could you talk a little bit about efforts perhaps to strengthen capacity of local government, to strengthen engagement in the way some of our other colleagues have communities at local level, even if the official leadership may still be quite centralized? Just interested in your reflections in a country as complex as India.
Well, we do have municipal corporations in most of the cities. They are allocated some resources and they also collect some taxes. But their decision-making power and the ability to execute major programs is very limited. Their powers are greatly curtailed by the overriding authority of the provincial government or even the federal government. And their ability to take many actions is greatly limited by the fact that they do not have adequate information either. Therefore, what we did is essentially recognizing that decentralization requires firstly giving them more financial powers and then providing them technical assistance. We have something called the Finance Commission, which every 5 years is set up to look at the allocation of tax revenues between the central government and the state governments. So we had appealed to the Finance Commission that health requires much greater attention, and as an innovation, for the first time, they devoted a complete chapter to health, which normally they don't do it for any sector. And they decided that we must strengthen primary health care. But when COVID pandemic broke through and this report was still in the final stages, they convened again after the first wave and asked for fresh learnings. And this time they decided that the funds for improving primary health care will go to the local bodies, to the municipalities, and to the village panchayats as they're called. So unless that financing is done, you're not going to be able to get the power. And they said primary healthcare decisions would be substantially made at that level. So that is one battle won. The next thing is, of course, to provide technical assistance to the local bodies who have not been used to handling this decision-making process and how to do the priority setting with the newly acquired resources. So now we are working on that in order to provide that level of assistance so that they can get more familiar with the nature of health challenges. Of course, they have awareness of the ground reality, but what are the potential solutions and how to choose between the potential solutions is a process that we are actually now assisting them with. So I think that is one battle won, but more to go.
Yeah, thank you. I think your point, really important point, is the resources can come, but if the capacity isn't there, they can't really be used effectively. I'm getting a lot of great questions coming in from our participants. So let me go to Charlotte from Ann Slovic in Sao Paulo. Have you used cost analysis of health policies as a way to demonstrate the benefits of health to in the political realm to make it more of a priority?
Yeah,
Charlotte?
well, I could speak for so long about this this subject. It's so important. We miss health economists, and there's something we've been talking also with colleagues here. I've been using some on air pollution, which are really useful because the French Cour des Comptes, the big finance organization, made an estimation of what air pollution costs on lives, on mortality and morbidity. But if as a mayor, I improve the health of the people, the money doesn't come back into my pocket, it comes back at central government pocket. But we spend lots of money cleaning the buildings. And when you have less air pollution, you have less cleaning of the building. And this was, we had the real cost. I don't remember it exactly, but we had the real cost in this study. And that was really, really useful. And I'm always trying to fight so that we can show how the benefits are global, but also local, and how we can improve in the pocket. And I think we really want to develop things on that. It's true in many sectors, and how many people you employ facing a situation, especially for people in lots of financial problem. And sometimes you have so many social workers coming, and when you do it better, when you put the person at the center and find another person, it costs much less. But we don't have formal study. And if I may just very quickly, I think it's how researchers can contribute. Text the politician, tell them, I want to study that. Do you want to study that with me? And people will say, oh yes, I would love to, because I don't know how to do, if you make it simple.
Yeah. Well, let's stay with that question, because that's another question from Ana Ortigoza, who was really saying, how could researchers contribute? She uses the term paradiplomacy, which may be nice having my rudimentary Spanish, maybe some integration of the word, but I think that maybe we could take it to the level of researchers really being effective in informing the actions of political leaders in cities, both within cities and in a sense being diplomats beyond cities for themselves. Mary, let me ask you to pick that up, and then we'll go to.
Well, I think that's really a great idea, and one way to do that is for governments to approach local research institutions and ask for assistance. Certainly, we did that in New York, and we were lucky that New York City had has a public university. And therefore it was easy to work with them from a contractual standpoint. But there are lots of natural experiments going on that should be assessed, and they, as you said, they don't have to be complicated. We don't need to agree to the idea that everything has to be a randomized trial. Just simply documenting that interventions that will help promote health can be delivered, and to my mind, often enough. I think I would just like to echo the call that Charlotte has made, that researchers step forward and approach local health departments or even city halls and say, we want to put ourselves at your disposal. and work with you to document impact. I just, probably Mayor Bloomberg is considered one of the most effective mayors in recent history in New York. And he came in saying he was going to redo education, and he left saying he was the public health mayor. There is a political benefit to improving the health of your population. And I think politicians can understand that.
Yeah. Dr. Reddy, I wanted to ask you, because having set up 5 public health institutes in India, which really were designed to provide more of an evidence base to political leadership, could you comment on this question about bringing evidence into the hands of what researchers could be doing, should be doing to strengthen governance?
Yes. If you really want enlightened policy, you need to present evidence which has scientific credibility, financial feasibility, operability, viability. Quite often we make the mistake that only scientific evidence is all that counts. So that's why you require multidisciplinary research. You require basically basic research, epidemiological research, clinical research to provide the scientific credibility. You require health economics research, you require implementation research for operational steerability, and you require social science research for finding out what the political viability is, who is opposing it, who is supporting it, all of that. And therefore, if we can actually gather evidence from different sections and then go and present the evidence, then it becomes easier for the policymaker to take a decision, rather than just set it only on the strength of science. Of course, I'm saying that these are all scientific disciplines, but multidisciplinary approach is required. Second thing, if I may just make a point about equity. We do talk about equity, but we must also explain to the policymaker, who is intuitively willing to accept the equity argument, that equity actually functions in 2 dimensions. One is horizontal equity, where everybody is entitled to the same services and privileges. But there is also vertical equity, where we are trying to bridge the existing equity gaps by trying to look at what additional services or resources we can devote to disadvantaged sections who have suffered health inequities and try and bridge them as fast as possible. So that is where we have to really tell them how we can actually combine a universal approach with a partially selective targeted approach. And if we present that menu, then they're more likely to accept it.
Thanks very much. I want to expand our discussion on the researchers, because Waleska Caffa from Brazil has asked a question of bringing researchers in to develop how do you measure governance in order to be able to compare experiences in governance. And I'm going to ask Remy, who's UN agencies tend to be those that provide standards for measurement, and what you're doing to try to answer Waleska's question, how do you measure governance? And then maybe ask Charlotte to comment after Remy on that question.
And I think the basic principle is that any measurement is based on the baseline. And if you want to measure change, you have to know where you are. So we go back to the question of knowing. I think it was Mary who was asking if you know, or Charlotte who was saying, if you don't know who you are tackling or what type of governance issue. So it's about the change, the type of change that we desire. And how do you measure that? If you, you have, you can say traditional way, but in the context of COVID, we don't have to necessarily say where things have worked. In the UN, it's very sometimes challenging to compare countries because they are all independent. Everyone will say, they have unique governance system. What we are looking at is that element of the outcome, where we say improve livelihoods, improve living conditions. So when you look at that, then you can trace back and say you can attribute that urban governance cannot be a single contributor. There are other factors, but ultimately, if that can enable that to work, as we have evaluated in our cities and pandemic report, where it was clearly established the link between some policy interventions and some outcomes. in terms of death rates, in terms of number of people hospitalized or vaccination compliance. So when you look at that, you can see that there is more synergy between those who are governed and those who are governing when it comes to public governance, for instance, or the governance in general. When you have resistance, then there is a clear issue of communication on governance in that respect. So there are many parameters where you don't measure directly, but you look at what type of changes are there and the compliance and some of the desired changes that you have. So I think that's what you should be looking at. If I were a mayor like Charlotte, and I wouldn't mind even if I improve the quality of life of people living in cities. They may still contribute to national, budget, but they contribute first of all in the city. So I think we have to always know that people think about themselves in a city before national government. And national government, and I think that's been one of the things we have maybe we have been misled to think that governance is really about national government. It's no longer the case. At the local level, they are more powerful, they have more networks, they know what they need, they can do something more there than national government. So it's a perceived thing, and this is eroding in many parts of the world, not only in federal system, but all systems. We can see that happening.
Okay, thanks, Charlotte. Let me ask you, just a question that was up there and disappeared, but I remembered it because it was important. We're asking about sort of measuring governance, researchers measuring governance, but another question had to do with researchers really partnering with civil society organizations in order to get the message perhaps to decision makers more effectively. Your suggestions, your thoughts about that for all of you really, because that's an important issue. Charlotte, and then maybe Mary comment on that one.
Yeah, no, agree. Sometimes it's more complicated to go to the policymaker, even though it's not always the case, because depending on how the municipality is, you may have entry point that you wouldn't think about. And sometimes there are great opportunities, and because globally the level of democracy and faith in policymaker is not very high, we miss opportunities. There are amazing people who have some power locally and would love to engage with you. Otherwise, making consortium with civil society, but with inhabitants, with community is so important. Community-led research, and you can see that all the work that Jason Coburn, also from ISU, is doing is amazing, and really make consortium and try to do that. But again, how do you measure governance? Sometimes it's really all the new science, it's new for me at least, on the boundary spanning. How much do you know the other people? How much do you know people within the silo of your municipality, within the silo of the association? They have been great works. I'd be happy to share some works. I evaluated my governance at the end of the mandate. I think nobody in my city read it, but we did it.
That's great. A very quick comment, Mary. You're on.
No, I'm just curious now how you evaluated it. I agree.
Yeah, we'll share that with everybody. I think that's important.
It's in French.
Yeah, no, I mean, I think in some ways it's intangible. But some of the things that you've mentioned, Charlotte, the fact that you knew somebody to call at the hospital, the extent to which governments become joined up and have a shared mission is something that there should be evidence of. And it certainly, to me, seems like it would be evidence for good governance.
We only have a couple minutes left, and I want to have one of the other questions said, what can health professionals, what can public health professionals defined largely do to try to make these changes to improve governance for health? Just a quick takeaway from each of you. Srineth, perhaps you could start.
Build alliances, adopt an agreed agenda, amplify advocacy, accelerate action, and assert accountability.
I like that. You're a poet of public health, so we're going to have to get that in writing from you. That's great. Remy, last, just quick takeaway from you.
Now we think about the network of governance. Governance is no longer only national public, it's really the network that I would like to take away, and that element of capacity. Not everyone had the same level of understanding, appreciation, and ability to respond. So equity is not necessarily putting on the same level, but empowering people where the needs are. Over to you.
Thank you, Mary.
I'd say that really Dr. Reddy has summarized it, but in seeking community engagement, and which is a source of accountability, right? It's important not only to go to the usual suspects, but to engage with your critics, and to look for activists in addition to advocates, and seek to get their input. And I guess I can't avoid saying that we have to, at least in the United States, tackle the issue of the budget that's available to public health. It's simply inadequate, and it has led to a very destructive impact on public health during the COVID pandemic. 150 senior leaders have left their jobs, and it was partly because they didn't have the resources to do their jobs.
Charlotte, quick takeaway. We're over time, but I want you to have a word as our former elected official.
Okay, be fun, use fun words, use innovation, use all the words that make people be interested in health. Don't be like, oh, you cannot smoke, you cannot drive, you cannot do everything. Show how public health is like so interesting and so the main subject. And then from that, you get the budget of other sectors.
Thank you. And I would just say 3 takeaways for me from listening to this fantastic panel. One is a picture is worth 1,000 words. I think we could all take that away. Secondly, really leading with equity. If you have equity, you get health. I think that's been a big lesson we've learned in this pandemic. And finally, Dr. Reddy's partnerships for public purpose. I've summarized his poetry. So thank you all very much for joining us, and goodbye.
Thank
Thank
you.
you to the
Bye,
panel.
thank you.
So long.